having diabetes mellitus type 1, kurus kering may badan.
We're having the dialogue today on diabetes and a nurse, and we're recognizing the role of nurses in fighting diabetes in Uganda. So on 14th November, we are commemorating the World Diabetes Day. This is where we recognize the tremendous role done by our policymakers, governments, communities, and on an individual basis on fighting against diabetes. We also take heart with those who are suffering or who have survived diabetes. And in this room, you have people living with diabetes who are ready to share experience and their stories and their journeys, how it happened, where they are, and what should really avoid, and what should really do to avoid such scenarios. On Saturday, 14th November, that means that's when we are celebrating World Diabetes Day. So we are recognizing it. Today we are having a dialogue, but on Saturday we are going to have a walk in memory of those people who have succumbed to diabetes, and also taking heart with those who are actually still moving with this journey and showing togetherness with the people worldwide that we are in the same thing together and we are ready to fight diabetes in all other scenarios. So I'll leave Mr. Chris, the Program Manager, Uganda International Communicable Disease Alliances, to give us a brief remark. Then we are officially opening our program. Thank you so much.
Thank you very much, everybody. Again, I want to welcome you. There are members who came in when we have introduced ourselves. I want to welcome you, and at an appropriate time, we request you to introduce yourselves. Maybe not everybody will have Idris Mukankwa, who is the leader of the Africa Diabetes Alliance. You're welcome with your team. We have a number of others who came in. I felt I should go through this and make this a statement before everyone, and then we'll get started. And then before I read this, I just want to thank the team that has been demonstrating. Dr. Suman, thank you so much for demonstrating before the people. Members of the press, I think you have all the questions. Where to direct your questions? The link, make sure all the questions related to diabetes are answered, so that you will not ask me next time we need to discuss other things. The other issues are, of course, when she demonstrated about the waist circumference, and Dr. Mo had given us the importance of waist circumference and why waist circumference and made as opposed to body mass index. The other issue that I always find is that most ladies do not know where their waist is. They can't differentiate the waist sometimes. So, but I think Dr. Susan has showed it very well. I have found it quite many times. World Diabetes Day is commemorated every year on the 14th of November to promote diabetes awareness and advocacy. According to the International Diabetes Federation, diabetes is the major cause of mortality globally, accounting for over 4.2 million deaths and health expenditure of about $760 billion. And this occurred in 2019. Worse still, 1 in 2 people living with diabetes are undiagnosed. So in other words, for every newly diagnosed diabetes patient, there is another one who doesn't know. If there is a new person who is diagnosed with diabetes, then there is another one who is not. You have, maybe Dr. in his clinic, if he gets about 5 new cases in a day, then there are other 5 that have not come to him or that do not know, and they are walking freely. The danger is not that they do not know when they have a side, but they do not know, and probably they are not bothered, and they are not thinking or seeking to know. So that's now the reason why we come here. That's the reason why we emphasize random and routine screening. So that the people who do not know, like Dr. Mo was saying, you are training young people, you screen them, people do not even know. The next time you realize, people start getting shocked and say, sure. So that's the very reason that for everyone diagnosed person, there is another who doesn't know. And in Uganda, the prevalence of diabetes is about 2%, and with type 2 being at 1.4%, and being the most, and diabetes type being the most common form of diabetes. The poor control of diabetes under the direct influence of lifestyle factors, lack of awareness in Uganda is the major contributor of the increase in the type 2 diabetes. A nationwide NCD risk factor survey conducted in 2014 selected the urban and rural areas of Uganda concluded that 95.6% of those identified with diabetes in rural areas were unaware of their condition. Quite far fewer, about 65%, were unaware of their health status in the urban areas. So that's what I was saying, to emphasize. Close to 100% of people in the rural who are diagnosed of diabetes, they do not know. And then 65% in the urban also do not know. He works for other treatment, or is moving in for other complaints. At the end of it all, they tell them they have diabetes. Diabetes exerts a huge social burden by reducing quality of life and life expectancy, as well as causing economic loss to individuals and nations. Now we look at diabetes amid COVID-19 pandemic. The global outbreak of the novel coronavirus has added new challenges, fears, and uncertainties. According to the World Health Organization, older people and people living with pre-existing medical conditions such as diabetes, heart disease, and asthma are most at risk of severe symptoms of COVID-19. The International Diabetes Federation highlights that viral infections like COVID-19 are harder to treat in people living with diabetes due to fluctuations in the blood glucose levels and the presence of diabetes complications. This is attributed to the compromised immune system, making it even harder to fight the virus and leading to long recovery periods. Secondly, the coronavirus thrives in an environment of elevated blood glucose. COVID-19 has exposed the health disparities in Uganda and how inequity of healthcare access and resources hurt our most vulnerable, and many of whom live with or are at heightened risk of diabetes. The reports from the Uganda Ministry of Health on COVID-19 deaths have indicated that more than 80% of all COVID-19 deaths and those with severe symptoms had diabetes or have diabetes. World Health Organization assessment indicated that fewer lower-income countries included the continuity of services in national COVID-19 plans. I think the Minister of Health should now look at this. In low-income countries, most continuity of care plans amidst COVID-19 did not look at NCDs. And no wonder we had a challenge when we had the first that we had in Uganda. Actually, it was very silent on NCDs. And then for us as UNCDA had to rise and look at it. Only 42% of low-income countries reported NCD services inclusion compared to 72% of high-income countries. In the assessment of 62% of countries reported disruption to diabetes treatment. So COVID-19 has disrupted the continuity of care in our healthcare system. Marking World Diabetes Day on the 14th of November 2020, this year UNCDA is bringing to the fore of nurses, the crucial role the nurses play in supporting people living with diabetes. Our campaign is centered on nurses make the difference in the fight against diabetes and ensuring that you make healthy choices to prevent diabetes by finding a balance between nutrition, physical activity, and mental health management. That's at individual level. Understand the societal and economic impact of diabetes. That's at community. Also, stand up for more accessible and affordable diabetes medicines, devices, and supplies for us as civil society. We support the nurses and the other healthcare professionals to get better diabetes education and funding. And that's why we are calling on the Minister of Health and Government to commit to meaningful engagement of people living with diabetes and other NCDs in all decision-making processes. We called and want to echo this, that for people living with diabetes and those who are at the verge and those who are living with NCDs, we would want to continue and have asked them and have already told us that nothing for us without us. When we look at the plans, the various committees and task forces that have been created to manage COVID-19 or to prevent COVID-19, we do not see the voice of people living within cities coming out. Deliberate effort in place to prevent this, and we know the prevalence of many cities in our country. Actually, we are getting to the level of an epidemic. So, if these people, and you know, we are looking at this, and when you look at the demography of the people who have died of COVID-19, those who have been diagnosed, most of them are people in the affluent class. So what I'm saying is 80% of the deaths and people who are getting severe symptoms are living with NCDs. So we would want to see deliberate efforts at every level of controlling COVID-19. If it is a committee, there should be somebody who is speaking for people living within cities. If there is any preventive measures that's put in place, it should be able and emphasize this, not just mentioning it in the passing. It should be emphasized. If we are preparing a healthcare facility that's managing COVID-19, then there should be something clear on any cities. And so that is what we really want coming out. And like I said, we have looked at the theme, and this year's theme, Nurse Make the Difference, and it's focused on the vital need for education and funding for frontline health workers. And according to the World Health Organization, nurses account for about 59% of all health professionals, and the global shortage of nurses in 2018 was 5.9 million. And 89% of this shortage was in low and middle income countries. The World Diabetes Day 2020 campaign aims to raise awareness of the crucial role that nurses and other healthcare professionals they play in supporting the people living with diabetes. With this, I still want to emphasize and echo that we look at the role healthcare workers play in managing NCDs. And For us, as civil society organization, together with people living with NCDs and particularly those living with diabetes, we will continue calling upon the policymakers, the government, to ensure that everybody lives a healthy life, even when they have NCDs. I will ask the board chair of Ugandan Non-Communicable Diseases Alliance to give us opening remarks, and then we conclude the program.
The Commissioner, Minister of Health, Dr. Charles Oyo. I also saw Dr. Mugabe Frank from the department, NCD department, Minister of Health, and your colleagues from the Minister of Health, our President of the Uganda Diabetes Association, all dignitaries present in your respective capacity, the media fraternity, ladies and gentlemen, I take this pleasure on behalf of the UNCDA to welcome you all for this dialogue during the commemoration of the World Diabetes Day 2020. The Uganda Non-Communicable Disease Alliance is the lead civil society organization and partner with Ministry of Health in the fight against NCDs in Uganda. It was established in 2010 with support from the Danish NCD Alliance as a response to the global NCD epidemic. It's an alliance of Uganda Diabetes Association, Uganda Cancer Society, and Uganda Heart Research Foundation. The alliance has since established 11 branches across 4 regions in Uganda, and we are also a member of the East African NCD Alliance, which convenes alliances from 6 countries in Eastern Africa. Also, the African NCD Network, Global NCD Alliance, and also we partner with World Diabetes Foundation, American Cancer Society, and others. Like Chris has said, the prevalence of diabetes has risen, and currently it's estimated at 463 million from 108 in 1980. And it's projected to reach over 600 million in the year 2030. In Africa, the prevalence has also increased from 3 million in 1994 to over 15 million people currently. And it's noted that the prevalence of diabetes is increasing in low and middle income countries where Uganda falls. Diabetes contributes 4.2 million deaths annually. And like Chris said, 1 in 2 people with diabetes are undiagnosed, unfortunately. In Uganda, the prevalence is estimated at about 1.6%, and that is data from the 2014 NCD risk survey. So, the World Diabetes Day, which was created in 1991 by IDF and World Health Organization in response to the growing concerns about the escalating health rate caused by diabetes, is marked every 14th November, which is also the birthday of Sir Frederick Banting, who discovered insulin in 1922. And the theme is the nurse and diabetes. It's aimed at creating awareness around the crucial role that nurses play in supporting people living with diabetes. Nurses contribute a big part of the health workforce. They account for 59% of health professionals. They are involved in screening, diabetes diagnosis, counseling, diabetes education, provision of treatment, follow-up, managing complications, and others. I would like to take this opportunity to thank the nurses in our midst. Please stand up for recognition. Sister Young, we have two nurses here. These people have been of many people with diabetes in Uganda. They've educated nurses, they've educated the patients, they've managed patients. We appreciate you so much for the work you're doing. UNCDA is committed to continue in the partnership with the Ministry of Health and other partners to create awareness of NCDs, but also diabetes, and also through our member association, Uganda Diabetes Association, to advocate for increased provision of affordable diabetes services. So let me take this opportunity to call upon all of us to join hands and make our contributions to the fight against diabetes. And we can participate in any way. Today we were able to screen for diabetes amongst ourselves. Speak to, because you are a voice, you're going to speak to the people and inform them that they should screen for diabetes. Inform them that they should take care of themselves. And in our presentation, we are going to see how we can prevent diabetes and its complications. So thank you, Minister of Health, for always receiving us and allowing to work with us. And thank you all partners for always heeding to our call and joining our voices in the fight against NCDs. Thank you. My task is simple: to welcome our dear Commissioner, Dr. Charles Oyo, and to say thank you for allowing commitment to the fight against NCDs in Uganda. And even came early. Thank you so much. You participated in the screening. So please, Dr. Oyo, we are ready to listen to you.
Allow me to take this opportunity to recognize the presence of everybody here, especially the team from UNCDA, Uganda Diabetes Association, Ministry of Health, the media fraternity, the invited guests, ladies and gentlemen. I'm Dr. Charles Oyo here, Commissioner for Communicable Diseases in the Ministry of Health. As we start the presentation, allow me to remind you that COVID-19 pandemic is still with us in this country. That it is on the increase, and currently Uganda is at stage 4 of the disease. Stage 4 meaning that there is widespread community transmission, and you cannot trace the contacts to the cases that have been registered. And for that matter, the best that can be done in this case is to mitigate the effect of COVID-19. And according to the report that was released yesterday, we have so far registered 14,704 cases of COVID-19 from 122 districts in Uganda, out of the 135 districts that we know. So apparently, every district is right now grappling with COVID-19 pandemic. And in that report, there were 130 new cases that was recorded, with total recoveries standing at 3,277 and 133 deaths so far registered as COVID-19. So we can see how bad the situation is. So this is just a preamble as we talk about NCDs. Otherwise, let me go straight to what I prepared. I must apologize that I didn't know the audience very well, and the presentation may prove to be technical in some areas. I thank you, please. But I hope you can understand that. Next slide. So I'll be talking about non-communicable diseases and COVID-19 pandemic in Uganda. So I'll start with the background, then conclude with the next steps in 5 minutes. I shall follow that up. Ladies and gentlemen, non-communicable diseases, as we know, is also called chronic diseases. And these are conditions that cannot be easily passed from one person to the other. They are not communicable, or they are not infectious. They tend to follow a long course and generally with slow progression. As it has already been alluded to, there is a growing burden of NCDs globally in both rich and poor countries. According to statistics provided in 2016, NCDs accounted for about 41 million deaths worldwide, and significantly 15%, which contributes to 15 million people, were among those aged 30 to 69. So these are people less than 70 years. And my youth is the most productive age group that we have around us. And over 85% of this premature death occurs in low and middle income countries. And of course, you know, Uganda is one of those. However, the current health system is generally skewed towards management of communicable diseases. And it's not well oriented towards chronic conditions. This is what we know. We tend to put a lot of resources, a lot of time and attention on managing conditions that are infectious in nature. HIV/AIDS, malaria, TB, name it. Ebola, even COVID-19. When you look at the sources that we put in those conditions compared to what we put in NCD, there's a very big disparity. Next slide. So, these are risk factors for non-communicable diseases. There's what is referred to as 5x5 approach. When you look at the common conditions, these are cardiovascular, these are heart and blood vessels, diabetic conditions, and chronic respiratory diseases, cancer, diabetes, and mental and neurological conditions. These are the major ones. There are also other NCDs that we later see. And the common risk factors across the board includes unhealthy diet, use of tobacco, harmful use of alcohol, physical inactivity, and air pollution. Next. Now, when we look at the burden in our country, the risk factors for behavioral component, we have heavy alcohol consumption contributing to 26% is main and 8% only in women. So generally, men are heavy drunkards, but they tend to abuse alcohol more than women. That is a very good thing for our females. While tobacco use, the risk is at 10%, and healthy diet at 88%, physical inactivity at 5%, and for other physiological risk factors, hypertension was at 24.6 less. Now, for cancers, in women, of course, the commonest was cancer of cervix at 36%, followed by breast cancer, 13%, and skin cancer, what we call Kaposi sarcoma, at 8%. But in men, Kaposi sarcoma has been leading, followed by cancer of the prostate in that body. And of course, about 10% of the people who are surveyed had chronic obstructive pulmonary disease, these are respiratory diseases and asthma. Now, when we talk of diabetes, And the related risk factors, of course, is more in urban areas than in rural centers. And generally, it was at 2.8%, disaggregated according to gender, males at 2.8 and female at 3. So it tends to be more in female than males. And of course, the overweight at 18.6%, and the obesity standing at 12.9. Physical activity was not measured because I think of some challenges. Now, of course, there has been alluded to already that Uganda is experiencing increase in cases of non-communicable diseases. And of course, diabetes inclusive. So when you look at this graph, which has been disaggregated in gender, males and females, from 1980 to 2014, when the survey was done, you can see that there's a steady increase in the prevalence of diabetes in this country. Rising slowly, but surely going up. Next. And in terms of mortality, about 40% of deaths registered in Uganda, according to that finding, were due to non-communicable diseases. And the 60%, of course, is other communicable diseases, including maternal and perinatal conditions and nutritional related conditions. But among the NCDs, you can see that injuries due to road traffic accidents, injuries due to domestic violence or self-inflicted accounts counted for 13%. And cardiovascular conditions are 9%, cancer is 5%, diabetes about 1%, and other NCDs are 10%. So this shows how significant NCDs is in terms of mortality in this country. Next. Now, when you look at the effects of COVID-19 on NCDs, first and foremost, NCDs predispose to infections. So that means there's an increase in vulnerability to any infection, including COVID-19. And it also increases the risk of developing severe form of COVID-19 disease, and therefore need for critical and continuous essential care. NCD also increases risk of dying from the COVID-19 disease because of the complications, as is a later onset. And evidence shows that with COVID-19, there's also a spike in mental illnesses related conditions discussed: stress, panic, anxiety, naming, which are later on seen in the subsequent slides. Next. So this slide shows COVID-19 comorbidities. When we talk of comorbidities, these are other conditions that pre-existing conditions that the patients have on top of the COVID-19 infection. This data is relatively old, not so new. Of the 395 cases that we have analyzed, 38% of comorbidities was due to non-communicable diseases. And those are the different conditions that were commonly registered. Hypertension was very high on the list, and followed by diabetes, 31%, and the rest in that order. So you can see how significantly NCDs contribute or feature when it comes to COVID-19 infections. Next. Now, in terms of death associated with comorbidities, again, out of the 92 cases that we have analyzed, 92 deaths, hypertension contributed to about 35, followed by diabetes at 32. And then cancer was 5 deaths, liver diseases in that order going up. So significantly, COVID-19 infection with NCD comorbidity contributes to very high risk of dying because of those complications. Next. Next slide. Now, we decided to look at the case fatality in terms of age group. You can see that this more or less mirror the most affected age group in terms of when we talk of NCDs. So those below 40 are generally at a very low risk of dying compared to those aged more than 40 years. But of course, people aged 75 years and above contributed to very significant proportion, followed by 65 to above, 65 to 74 in that order. Next, so 8 plus comorbidities, or 8 combined with NCDs plus COVID-19. It's a very terrible problem in terms of risk of dying. Next. So during this COVID-19 pandemic, generally we had disruption in health services, and that did not spare mental health services. As you may be aware, the mental health units in all the regional referral hospitals were seen as a soft target for isolating COVID-19 patients. And patients who are admitted by them had to be either discharged or transferred to Bika for further management. And this is a very big challenge, of course, but we are aware of the need to address infectious, highly infectious conditions or any disease outbreak. I will not talk about the global picture, but I'll just continue. This one shows you how the services were disrupted for the different conditions. Next. Now, I want to look at the trend of diabetes, whether the service provision and cases remain constant during this period of time. When you look at January to March 2019, after October, December 2019, generally these are cases that are seen in our patient department, country-wise. There has been an increasing trend. But January to March, some of the cases reduced, but of course when you compare January to March 2020 and January to March 2019, you can see that there's a slight decline. But more significantly, after the lockdown, of course, in March, you can see that the services, OPD attendance with diabetes reduced. And from April to June was slightly trying to pick up, but I must admit that right now, the situation is slightly better because of the leak. Next. The same applies to hypertension. From January to March this year compared to January 2019, we registered significant attendance in OPD cases due to hypertension. This may be related to the programs and the different interventions that have been in place, increase in the general screening of the population and all that. But subsequently, from April to June, there has been a very sharp decline because of the restrictions that are on. Next. Now, the trend of cardiovascular accident or stroke is still the same story. Look at the same period, Jan to March 2020 compared to Jan to March 2019. You can see decline. This could be related to reduced access to services. Next. This is about a trend of cancers. The left graph shows the trend in 2019 for the different cancer of cervix, prostate cancer, breast, and all the rest. And then the one on the right shows the trend in 2020. Again, look at the period from March to May, on this side, on the right-hand side. Whereas on the left side in 2019, we are registering an increase in all those different conditions. Here we registered significant drop. the number of cases that were attended to because of COVID-19 pandemic. Next. Next slide, please. Yeah, this is about the same thing that I talked about, but teasing out breast cancer. Again, it's the same situation. The picture is not any different. Next. This is prostate cancer. You can look at this, the bars on the extreme right. Serious reduction, the number of cases that are attended to in our cancer. Next. Injuries. Again, same situation, but of course, during the lockdown, the traffic was significantly reduced on the road. So cases of injuries went down. But injuries due to domestic violence generally increased. And probably this would explain what you see on this graph. Next. I talked about increase in cases of mental conditions, and this graph shows the referrals to the Kabika National Referral Hospital. When you compare, look at the trend, whereas the trend generally is on the rising one, in 2019-2020, there has been a very significant increase in the number of cases. We know COVID-19 brings a lot of anxiety, a lot of stress, a lot of those conditions. So that would explain. But of course, in a way, it would also be attributed to the fact that some regional referral hospitals or most facilities were closed, and the only available services for mental health conditions that has been running consistently is the Kabika National Referral Hospital. Next. Next slide. These are total admissions. It's about what I alluded to in terms of actual numbers. Next. Now, I'm about to conclude. In terms of NCD supplies, when you look at these, especially the items that is commonly used in managing non-communicable diseases, we have medicine like the Philippine, Pactoprin, Metformin, Dibrentamide, insulin, acting, cardiac asthma. You can see that some of these medication has been expiring in our facilities because of limited access to services during the period of lockdown and immediately after. Because consistently, the message out there is that NCD is predisposed to restock COVID-19, including dying from COVID-19. So generally, some of these patients have been shying away from going to facilities for services for risk, to avoid the risk of contracting COVID-19, which would be very risky to them. And then besides that, services tend to focus more on the COVID-19 than the general care that we have been providing for chronic care. Next. So what did we do as the Ministry of Health to address some of these issues? Government developed guidelines for managing NCDs during COVID-19, especially on continuity of essential services to address the critical needs of people living with non-communicable diseases. Communication has been issued out to the different hospitals, regional referral, including national referral hospitals, to the districts to prioritize NCDs in their intervention. And we ensure that data is collected on NCDs and COVID-19 so that analysis could be done to inform decision making. Some of these interventions have been informed by data that was collected. Next. That's a very example of the document that was prepared by the government. And of course, the advice to this was to integrate NCDs in their performance reviews. Whenever they are conducting performance reviews, they should look at performances of NCDs interventions. Next. This is the guideline that was developed. When you look at That number 3, that is prevention, management, and control of non-communicable diseases. So there is a list of prioritized service package. For instance, number 1 is management of non-communicable diseases, including mental health, hypertension, diabetes, cardiovascular diseases, chronic obstructive pulmonary diseases, including asthma, cancers, and sickle cell disease. Then, of course, oral health and the rest. So this has been prioritized at all levels. Next. Nevertheless, we have some challenges. Talk about disruption of services because some staff are realigned. You can postpone some of the community interventions like cancer screening. So that was a very big blow to us, but of course, while trying to solve another problem. We are in the inadequate recording and reporting of NCDs, especially at lower levels. Then inadequate public awareness about availability of NCD services. Some people do not know where to go and what kind of services are available at what level. And limited supply of NCD medicine at all levels. Might also register some expiring. Some facilities, most facilities actually, do not have adequate supply of NCD medicine and related supplies for screening, especially test kits, among others. Even our health workers are not skilled enough to provide some of these services, especially at the lower levels. So this continues to be a challenge that we have to address as a ministry with our stakeholders. And then limited funding for NCD's activities. This is a very big one. Whereas we have limited funding in the health sector, according to the Buja Declaration, we have 15%. The budget should be for health sector. Our stands at 7.2% as well. It's slightly higher for some countries in the neighborhoods, but still below, less than half of what we expect. So maybe the oil money will come and help us. But I believe with the resources that we have in the hands of the different stakeholders, we should be able to prioritize NCD addressing there. Next. Wow, I have some recommendations, of course. We need to prioritize NCDs and integrate it in our routine service delivery, mobilizing additional resources, advocating for multi-sectoral actions and community involvement for NCDs, especially COVID-19 response, and then, of course, adapting some public deliveries of services and innovative models to improve access to services. For instance, introducing community dispensing points for NCD medicine with increased access. Next. And building capacity for chronic disease self-management to limit and counter the service providers. I think capacity of persons can be built so that they're able to address most of the issues at home without necessarily going to service providers to minimize the risk of COVID-19 and associated transport costs, because this is a chronic care. And integrating regional medical checkups for NCDs in all routine health activities at all levels. So I'm glad that we're doing some checkup today. UNCDA, thank you very much, and the team that is doing the work. This should be the way to go. Whenever we have any function, I think we should be able to just pop in and do what we can. You'll be surprised with the results that we find. And then investing in operational research in order to inform policy, strategic planning, and sound interventions. Next. So in conclusion, everybody is at a risk of acquiring NCDs. However, the risk may be reduced through simple preventing measures. Such as physical exercise, healthy diets, avoiding alcohol, smoking, substance abuse, and regular medical checkups. Persons living with NCDs can live a normal life when they follow professional medical advice, including adherence to COVID-19 guidelines. And NCDs generally negatively impacts the national economy and household. This has already been talked about. And there is need for collective efforts and responsibility in dealing with non-communicable diseases in this country. And go to the acknowledgement, ladies and gentlemen, allow me to take this opportunity. This is just the next step, you can skip it, to acknowledge all those different stakeholders, starting with the government, the ministry, health, all development partners, this local government, civil society organizations, educational institutions, cultural and religious institutions, people living with LCD, the media fraternity, the private sectors, and all those who have contributed in one way or another to address the problem of non-communicable diseases in this country. So the war against LCD should be fought at household level. And we need to take that responsibility as citizens to do that. Our partners to support government efforts so that together we can make a significant impact. Thank you very much for this. Thank you for working my family.
Protocols observed. My name is Josephine Jam, as you have heard, Secretary has already mentioned. I'm a diabetes specialist nurse educator, and I've served since I was trained, and it is now over 20 years, I think. So the patients I started with when they were young, they are now adults, students. So I feel so proud that I've done this work all this period. So I'm just going to highlight, as you have seen the topic or the theme of this year's World Diabetes Day is the diabetes and the nurse. So if I may say, who is the nurse? I think if I was to ask you, we would get so many answers. But to be called a nurse, it means you have been trained in a well-recognized training school for nurses. You have passed and you have been certified and you have been enrolled and you have been licensed to practice from the government body, that is the Nurses Council, which is under the Ministry of Health. So, if I go deep, who is a diabetes nurse? We know very well that everybody can manage diabetes, but you can't manage it completely in a fullness if you have not undergone any extra training. So a diabetes nurse has undergone a special training in the management of diabetes. So it has a step ahead of a general nurse. And this one is a specialization. So if now we say what is our role, briefly, what is a nurse's role, or a diabetes nurse's role in the management, we know very well that all over the world, the nurse is a frontline manager of a patient. Why do I say this? When you go to a health center, a health facility, even when you go to the clinics, when you go anywhere which is dealing with health, it is the nurse that you meet first. So it makes this nurse important. It makes this nurse to be recognized. It's a frontliner. By the time the doctor comes, a trained nurse should have performed so many things to sustain this patient. if a patient comes, like if a diabetic patient comes and is very sick, maybe the sugar is very high, maybe the patient is collapsing, without a doctor, this trained nurse should be able to do something so that by the time the doctor arrives, the patient's life will have been at least saved. So, therefore, the nurse is very important in this management. So, the first role of a nurse, or one of the roles of a nurse, is counseling the patient. We know very well, and I think so many we have witnessed, if you are a health worker, you have witnessed a patient who has been diagnosed. How do they behave? How do they take it to be told that you have diabetes? I have the witness. People come and call on you crying. They know death has come. Even others, I remember my colleague who is a health worker, who is a nurse. She has been over 5 years with diabetes, but she came happy telling me, I was told that when you get diabetes, you don't live for 5 years. So you die, but I'm happy I've now lived for more than 5 years with the diabetes. So that's why, as a diabetes nurse, counseling is very, very important in the management of diabetes. People come with so many myths. People come with, they have given up life. They know it is death. So a nurse, a diabetes nurse, has a lot of work to tell this person who has been diagnosed with diabetes what he should do, how he should live, and what he should expect if he follows the advice of the doctor. So this is a very important role that a diabetes nurse, to each and every patient who comes, must give the information. There are other patients who come when they are already, they become so depressed. They come when they are feeling, their reactions are so unique because of that news that I have diabetes and I'm going to maybe to die in a few years' time. So counseling is still very stressed in the management of diabetes. Another role which is also very, very, very important is the nurse. The diabetes nurse is an educator. What do I mean when I talk of an educator? What do they educate? So education in diabetes is another very important wing. This patient, for this patient to survive, he has to know that he has now a new disease in him or in her, and he has to adjust with so many things. He has to adjust in his nutrition. He has to adjust in his lifestyle. He has to adjust and be ready to take the medication every day. He has to adjust that he should go for screening or for tests. And also, maybe if he has been put on injection, he has to adjust that I'm going to be on medication every day for life. Maybe twice a day, maybe 3 times a day. So for a For a patient to accept, the nurse has to be very, very close to the patient. He has to be very effective. He has to be very, very near the patient. Otherwise, if we don't go near and we educate them, then the patient may not make it for a long time. Another advantage of education is that we should make our clients know that diabetes is one of the chronic illnesses. So the patient or the client may not expect to recover soon. If we don't tell them, they may go take their medication that has been prescribed and given, and they end up, and after some time, they say, the medication the doctor has given me, I'll finish it, I'm okay. So we have met some of these people coming back to the hospital with a poor control of sugar levels, and then when you ask, they say, no, I stopped because the medication I was given, I swallowed it very faithfully, and it is over. So it comes back to us. Have you given the information to the patient? Or you have just given, go and take this medication twice a day, and then you stop there. With this non-communicable disease, which is chronic, you have to have a lot of information to give the patient, so that the patient may know what is ahead of her or him. And then, in case this patient is able, we always encourage them, get your glucometer, get your blood pressure machine, and we teach them how to use. Or even those who have stories to them, teach them how to use. This is very important because they need to know how they are faring every day. They might, because diabetes or sugar levels is always fluctuating. Sometimes it goes very low, sometimes it is high, sometimes it is normal, and if it is low, how do they feel? So when they check themselves, they are able to know. So those are the things we give them the information. And also even the drugs. We don't give them drugs and leave them to go, like we are giving for malaria, or for urinary cough, or for what. There are certain things that we need to inform them about. For example, the time of taking. How do you take? You should not take without food. You should take in time. And if maybe this patient has been given injection, then you have to specify which injection are you going to have. How should you inject? How do you inject yourself? How do you keep your medicine? How do you keep your syringe that you use? These are all the information that is engulfed in diabetes education. And that's why I said this is a very important role that nurses should do. And it should be a knowledgeable nurse, trained. Otherwise, if we say everybody is giving, then we should have different information for each and every patient, and we shall lose them. A diabetes nurse is among the team of health workers who are managing the patients. They are practitioners as well. That's why, in the absence of a doctor, the diabetes nurse can prescribe, can initiate the management, can adjust the doses of the patient, can treat. So is a practitioner, she can treat the diabetes. Another one is community screening and awareness. And I think this is a very important issue as far as prevention is concerned. We shouldn't stop in the hospital and wait for people who are already sick to come and treat. We should get them from the community. We should prevent. So by screening, by going to the community, screening, giving awareness talk, they have become aware and they say, oh, the other time the nurse told me if I'm drinking a lot of water, if I'm eating a lot of, if I'm maybe passing a lot of urine, there must be something. So they run to the hospital or to a health facility and they are able to be checked. So for that matter, they can be captured at an early stage. Not to come to the hospital when you already have a wound on the leg, maybe the eye is not now working well, maybe other complications. So screening is one of the issues, the role of a nurse. The nurse is a teacher. Knowledge, you always give the knowledge. You don't get the knowledge and keep it. So once you have been trained, you have to give the knowledge to others. So therefore, we are much more involved in teaching health workers, in teaching students, in teaching even colleagues, in teaching even the community. We want everybody to be aware. And I think to the extent that we have done, that awareness has contributed to a number of people going for health care. Because at least they are aware, when they get an abnormal behavior or abnormal conditions, they always run. They want to check themselves, and they always come. A nurse has to follow up this patient. We always want to follow and see how our patient is doing. For example, if I get somebody who has been found with diabetes, I don't leave and just say, okay, get the medicine, go. I should be able to follow. How are you faring? What are your challenges? How can we work together? How can we help you? So a nurse has this work to do for the patient. And even the nurse can follow up this patient if there is any means, can follow up in the community, can follow up in their homes, and then is able to help this patient more out of the health facility setting. This nurse is an advocate or is a mediator of this patient to maybe to organizations, maybe even to the ministry, maybe to anybody that can help. How? During certain periods, I remember, like, if the patients are not having enough drugs, the patients are not able to screen themselves, it's the responsibility of this nurse to go and talk to maybe the responsible person in the hospital, maybe the director, maybe anybody who is able to help this patient. and this is a very important thing as well. So other than that, the nurse is very actively participating in the management of diabetes, both in the ward, in the community, and everywhere. This is what I can highlight as the role of a nurse in the management or in the prevention of diabetes. Thank you so much for listening. Thank you.
And here from maybe people who have enjoyed the services of the nurses and other health professionals, but also we discussed the challenges. We don't have to, it's their time, it's their day, but they should be able to share with us the experience. Thank you. And Edith McCarthy is going to lead.
So we have seen, we have varieties, different age groups, and that one confirms to us that diabetes is for every age, is for every sex, and it can get anybody. And by the way, everybody is potential diabetes. Nobody should say, I cannot, because there are so many causes of diabetes. So we cannot say, no, I cannot have. So we want to have their experience. Maybe I start with the
we are going to start with the introduction, and actually, after you introduce yourself, thereafter we shall be sharing our experiences. Okay. Yeah, you say your name, then you tell us for how long have you been, or have you lived with diabetes?
Good morning, everyone. My name is Edith, and I have lived with type 1 diabetes since I was 16. So this year I make 15 years living with type 1. Yeah.
I'm Yancy Siabunya. I've lived with diabetes for the last 19 years.
My name is Hidaya, and I have lived with diabetes for 2 years.
I'm Richard Sanchez from Entebbe. I've lived with diabetes since I was 23. I'm now 45. I'm going to make 46 on 17th this month.
I think let's start with Sanchez. Kindly share your experience, starting with how did you realize, how and when did you realize that you have diabetes, and what was the experience when the doctor or any other healthcare worker broke the news to you that actually you have diabetes?
In 2002, I started getting signs of urinating so much, and then I was always feeling so thirsty. Even if the weather could be very cold, I want to take something very cold. Then when I used to urinate, I tried to check my urine. There was too much sugar in it. It was sticky. Then I started asking myself, there must be something wrong. Then good enough, I had friends who are medical personnel. I asked them, they told me, no, let's check your urine first. When they checked, there was too much sugar. Then they said, no, and proteins. They said, no, you go to the Entebbe grade B, they check your blood. Then because during those days, glucometers were very rare. in a clinic. So I went to grade B, and good enough, there was a diabetic clinic. When I reached there, they checked my blood, and they saw that I had diabetes. So they first put me on metformin and glucosamine. Then I also rushed for herbal drugs. I combined. By then I had no child. Then I said, will I get married? Will somebody really marry me with this thing? I said, let me leave it for God. Then I went on taking those drugs, but sincerely I wasn't educated very well because the way I was feeding was not good. Not until like after 3 years, then I got good education on my diet, started lowering somehow. I stabilized somehow, but as you know, diabetes, today is high, tomorrow is low, the other day okay, like that. Now in 2003, I got my first child. I delivered from grade A hospital, and she had no glucose completely. But good enough, the doctors were there, they injected glucose immediately, and she survived. Then in 2006, I got another baby boy. He was almost going to die because the midwife, I was trying to tell her what to do. Then she was as if, she told me, I have Rugesi. Then I kept quiet, but when the doctor came, my baby was almost dying. Then they injected glucose until he recovered and is alive. Now in 2015, something pricked me because my foot, both of them had started, I had started feeling paralysis. So something pricked me and I didn't see it. I moved with it, it was metallic. To church, reaching there, my daughter told me, Mommy, you have blood down. I said, where is it coming from? To check, the metal was still inside. So we pulled it out. We tried to treat, but within a week, I had started feeling fever, too much pain. Then the second week, it had swollen so much. It started discharging smelly liquid, not even pus. It was water and too smelly. Then we have our chairperson, the diabetic clinic. She rushed to me, they called her to my home. Then she said, no, this is beyond Entebbe, we should go to Mulago. No, we first went to Kosu in Entebbe, but because of the charges, we could not manage. Then they drove to Mulago. Reaching there with my chairperson and my relatives, Sister Ejam was the first person to welcome us, to receive us, and indeed, she did a great job to see that my life was saved. But I'm assuring you, by the time we reached Mulago, within the 2 days, weeks, the food itself was like fish, as you could remove the flesh of the fish and leave the bones alone. That was the nature of and I saw maggots, I myself, coming out of my foot. Now the time I reached there, I was anemic and what, but still Sister Jam played a big role, and I accepted myself. I knew death had come, and I was ready for it because the pain was extremely beyond my understanding. It was just around here. I said, no, let me die. I cannot bear this pain. That was my prayer. Because whenever, I'm a good Christian, but whenever I kept quiet praying, I was just praying to God to call me to die. I was not expecting life after. Now, after a few days, definitely they had to give me blood. They had to do what treatment and what. Then after like 4 days, I was put on the list for theater, and I was very much ready, but I was praying that I should die on the table. Now, they took me to the theater, it was night, and they did what they did. But I waited for death. They completed, I didn't see death, I was still alive. They said, oh, how am I going to survive with one leg? That was my question from the theater. It was something very hard for me. I was just thinking of death every time. From hospital, when I went to home, things were not all that easy for me because I'm a single mother. My mother died some years back. Before, I had finished the senior six, that's when she died. Now I said, who is going to take care of me? Said I should just die. And all the time I was praying to God that maybe I die because I thought maybe I was useless now. Because I thought of two things. Who is going to take care of my children and who is going to take care of me? Get for me the drugs, what to eat, this and this. I said, no, I should just die. But with God, everything is possible. I want to tell you that I reached an extent. Amid all those trials, I called even those people of A+ one day. I called them. I asked them, how much is the coffin? I listed the lowest price. They told me 500. Then I asked them, they asked me in terms of packages, like transport inclusive, what. Said, no, let's go slowly. How much is the coffin? They told me 500. Said, okay, that one I can manage. Now, I asked them, how about if the body is how about transport for the body? They said, that one depends on the distance. Then they asked me, where is the body? That was the biggest challenge. I myself, I was almost the body. I said, no, I'll call you later. What I want to tell you is that when you are amputated, things are not always good, unless when you have God. Now, amidst all that, after 6 months, I had to get an artificial limb. But remember, I wasn't working. I had nobody special to take care of me that was going to buy it for me. I got to someone, a friend of mine, I asked her, can you get for me a loan from your village, whatever? She told me I can. Then I asked those guys in Mulago, orthopedic department, down there in Mulago, near paramedical. Those guys, I hated them, but now I forgive them because I feel my heart is relieved. Now, when I asked them, they told me 1.5. Said it's okay. I borrowed that money. I called them to my home in Entebbe. They came because they knew the money was there. They came, two men, gentlemen. When they reached my home, definitely they took the measures, what, and I gave them the money. Now when they took the money, instead one was just an assistant there, but he pretended as if he was the big boss. Me, I didn't know. When they took my money, time came for me to go and practice to take another measurement. Then they give me the artificial limb. What they did, they gave me a fake limb because from here, it was just plastic. Yet they have to put a metal here to support the weight. Now, after 2 weeks, it broke. Yet I had not even completed the other loan. Going back to Mulago, asking for that guy, what were the people in the department were just looking at me with mercy. They said, how much did you give him? I told them. They were querying. Definitely they couldn't tell me the truth, but eventually I got the truth that they cheated me. But good enough, you see, when you trust God, He can do everything. In 2017, when I was still there, querying where to get another money to go and get another limb, I got a friend of mine. She just told me that God spoke to her that she should buy for me an official leave that I should start working and resume my work. And I thanked God for that. She's a friend of mine, and we are tribe mates, but it's just God who spoke to her. And she paid 2 million for me. With it. After that, she gave me transport, always to take me to the hospital to get Daddy. And that's why you see me now walking. You see? So I thank God for that. And now what I yearn for and what I'm doing, whenever I hear anybody who has been amputated, I rush to that person, one, to cancel that one, him or her. Secondly, to educate that person. Because, and I've achieved that because I managed to handle somebody, a lady who was amputated. She was in Zambia hospital, and I mean, because of all those, she said, no, if I don't die here, I'm not going back to my home, because everybody will come and look at me in the whole village. I'm the only one who has one leg. What that shame, kind of. But when she was brought to my home, I handled her for 7 months. I treated the wound, because in Zambia, when they amputate, they don't close immediately. They leave you to go. Then after like a month, that's when they do refashioning. But I managed to handle her in my home because I'm a nurse. I managed to handle the wound until we achieved. It healed very well. We took her back for refashioning, and now she's doing very well. She's in Rukova away. And very many others, they do call me for counseling and education. I thank God for that. I'm sorry, I'm not putting on the mask. And like 3 weeks, I was on admission in Chirud Hospital for 5 days. And even I have spent another 3 days in Entebbe, Dr. Kaldes Hospital, because I had developed a heart problem and my breathing wasn't good. So I was on oxygen like for 8 days. So now when I put on the mask for a long time, I'm not comfortable. I'm very sorry. Thank you.
Because of the ethics in health. So we have the mother there, Namtebi Farida, and she's going to speak in Luganda to share the experience of her child, and actually her experience as a mother with a child who is suffering with diabetes type 1. Mama tusanyisa okulaba.
Amanya gange yenze Namtebi Farida. Yenze mama wa Hidaya Apartment. Hidaya amaze n'obulwadde emyaka 2 okuva we yabufuna. Yabufuna mu 2018. We twategerera Hidaya ng'alina obulwadde twali tetumanyi. Naye nga gwe maama obanga gwe omuzadde otunuulira omwana wo n'omulaba embeera gy'alimu, n'olaba bw'abadde bw'ali n'essawa ya kakati gy'alimu. Namutunuuliranga nga mulaba aluzinze weight, okunywa ng'anywa nnyo nga si kitaddeeko birowoozo lwaki anywa nnyo ate ng'afuka nnyo. Lwali yali Friday ne ngamba taata we tomutwala ku ssomero, tumutwaleko ew'omusawo tulabe kiki ekimuluma. Ne tugenda ew'omusawo ne mugamba mbadde nsaba kebera ku mwana wange. Mubuuza nti nno omusujja gukuluma? Agamba nedda, omusujja teguluma. Ne mubuuza ki ekikuluma? N'angamba ndi fine. Ne mugamba oli fine ofaanana bw'otyo nti. Bwe natuuka ew'omusawo, omusawo mu kumukebera yaŋŋamba omwana alina malaria. Sinze yamutwala, taata we yamutwala n'amugamba nti alina malaria. Bwe yamukomyawo ne mubuuza kiki kye balabye, n'angamba balabye malaria era n'eddagala lyerino. Bwe twamuwa bwe tutya eddagala bwe yatabukira. Ekiro kyonna twasula tutudde, nkeera ku makya muzzaayo ne mugamba omwana wange bamuliise wano, naye ate ng'ayongera kuba bubi okusinziira nga we yabadde. N'angamba kirabika amakerenda gagaanye, tonkuba episo. ne mugamba no togenda mukuba mpiso soka ombulire ki ekiri mu mwana wange nagamba malaria konze malaria eddagala wamwadde nga lyamaanyi singa atereddemu ne mugaddamu omukebere nagamba namukebedde yesterday ne mugamba yes wamukebedde yesterday naye sinze yamulezi njagala oddemu omukebere kati nagamba nedda sigenda mukebera nkugambye tonkuba empiso ne mugamba togenda mukuba mpiso omwana wange si wuwo oba tomukebedde tewali buzibu tugende ewalala ne tweyongerayo ku ddwaliro eddala tutuukayo ng'ate kiri waasi okusinziira nga we kyabadde ne bamuteekako ekipa ya glucose nga tayogera tatuula takola ki jjukira alina sukaali tetumanyi ate bataddeko glucose wamma embaga neegula kaakati omusawo naŋŋamba ye omwana nkebedde buli bulwadde bwonna siraba bumuluma siraba kimuluma ne mugamba ngambye yasoose alina malaria nagamba talina malaria ne mugamba ate typhoid nagamba talina ne mugamba kati ki ekimuluma nagamba sikiraba omwana we ekimuluma ne mugamba gwe oba omulaba alyoke nagamba talyoke ne muga kati gwe oba tomulaba kimuluma kati mukolere ki omusawo gwe oba ngambye nti ekimuluma tokiraba kati mutwale musawo kyekisigalidde kubanga kutolaba bulwadde nagamba nedda simukugambye mutwala musawo naye kakati nze naawe njagala tubeere omusawo w'omwana ono ali atya netandika okumunyonyola ne mugamba omwana wange bukyanga muzaala by then yalina 8 years bwe yabufunira ne mugamba bukyanga muzaala okutuuka kati talwalangako okugenda mu ddwaliro wadde omukuba empiso okuggyako oba ssenyiga ne mugulira eddagala lya ssenyiga naye tebamukubangako wadde empiso nangamba kakati tukoze tutya njagala tubeere babiri tujjanjaba omwana ono okulya ne mugulira engeri gy'alyamu ne mugamba okulya alya naye bw'abeera ng'alinamu oba ssenyiga oba ki akendeeza ne mugamba okulya yakusaze n'ambuza ate okunywa koza okunywa anywa atya koza okunywa kwansobedde kati ate anywa nnyo n'okusinga luli nangamba get serious ne mugamba ye okunywa anywa nnyo naye ate era n'okufukaafuka nnyo ne mugamba yatandise n'ofuka ku buli ecupa n'agipoozinga nangamba naga abeerawo nzije nagenda naleeta gulukometa okugenda okumupimanga ngamba lwaki obweda tongamba nti omwana alina sukaali ne mugamba sikiwulirangako ne mumatu gange nanga omwana alina sukaali ne mugamba sukaali akwata abaana bato nze bujo mmanyi sukaali akwata bantu bakulu bakadde nangamba omwana alina sukaali nenzirika ne mutunuulira nga nze nkimanyi omuntu yenna bw'abeera ne sukaali aba alina kufa kimanyi nangamba nedda nensirika netandika okulowooza kati abaana banga ndeesa omwana bwe baawulira eri mu kalumu netwali baali balowooza omwana afudde awo embeera eyaliwo naawe okitegeera essaawa eyo nga bakubye bomu ne mugamba singa bagambye nti omwana nga alina siriimu kyandibaddeko kale nangamba siriimu omumanyi konze be nali mulwazizzaako mbamanyi singa obeera okkiriza nangamba ne sukaali naye bw'oba okkiriza omwana era abeerawo era omuntu obeerawo osobola okufuna sukaali nga bakakuzaala n'okula n'okaddiwa ng'omwina ne mugamba olimba tekiriiyo nze manyi sukaali akwata bantu bakulu bakuze ne batugamba genda ekiruddu batugamba ogenda ekiruddu tuba tutegeka engoye tugende ekiruddu ne wabaawo omwami n'atugamba nedda mugende emulago bagenda bangwiza ekiruddu batera kutwalayo bantu bakulu ne tugenda emulago tutuuka emulago bambi batufaako bulungi nnyo ne tusangayo nansi bamuyita Joffrey n'atutwala n'atufunira omusawo bamuyita Dr. Piloya. Dr. Piloya n'atwangwiza embeera naye okutuusa ewa Dr. Piloya bwe bamunzigyako bwe bati namala ennaku 2 nga simulabako nga bagamba bugambi leeta kino ne bagamba mumbulire omwana wange yafudde ne bagamba omwana mulamu naye gwe leeta obaba ne bakusaba olugoye ne bakusaba pampa ne bagamba pampa omwana wa 8 years munsaba mutya pampa ne bagamba gweza oba oleeta nga tuli mu ICU gye batusindika yamalayo ennaku 2 nga nze simulabako olwali olwokusatu ne bagamba genda omulabeko ntuuka ku mwana nze ebintu bye namulabako nali ngambiraba mu firimu nga mulaba mutaddemu bino ku nnyindo ku kangalo bataddeko akantu omutima bataddeko waliwo wali eri ekyuma ekibala nga obulamu bwe buli wali eri ku kyuma bwe babulabira abasawo ne baŋŋamba kati ateredde ne mga ateredde nga tetayogera tatunula takola ki ne baŋŋamba ateredde gwe mulinde mukidda kikojja ndaba n'enzirayo ebweru naye nga tebakukkiriza kuyingirayo omuntu mulala nga si gwe muzaddewo era ng'ogendayo kaseera otuuka eri ojjamu engatto oba byolina ne bakuwa engoye endala noyambala n'engatto ezigendayo nazo ndala ebyo nabyo nali siddabangako nasooka birabira ebyo bwe twavaayo then ne batuwa woodi twamalayo wiiki 2 ne tuvaayo bwe twakomawo ewaka bw'oba waakafuna ekintu obeera desperate ono bwakugana nti kozesa kino ng'olaba kyolina okukola ne bagaa nedda omwana mufunire habo agenda kumuwonya nga tuvuddeyo emulago tumazeyo wiiki 2 tukomyewo ewaka ne batugamba agenda kuwona gwe mufunire habo agenda wona buli muntu n'akuwa erirye naye mbakakasa waliwo omusawo omuwandi gwe bagamba abeera kayunga bagamba yansaba emitwalo 25 nagenda n'emitwalo 10 naŋŋamba kankwerire eddagala naye eddagala lyange terikolagana na mpiso bw'oba otandisa okumuwa eddagala eryange todamu kuba mpiso terikwatagana wona omukubira bwoti empiso ogenda kuba oweri netunula neŋŋamba katonda wange kiki ekiddako netudda ewaka bwe twamuwa eddagala within 2 days twali tuzzeeyo mu ICU 2 days ng'avuddeko ku mpiso nga tali muzikuba twali tuzzeeyo ne bambuza omwana wamuwadde ekinembabulira ne baŋŋamba nkubuulire ekyamazima kyetutakugamba oba kyebatakugamba naye nga nsuubira bakansala bakugamba kituufu bakansala bankansolinga naye ejjukira bwe nadde waka ne baŋŋamba gundi yawona yanywa habo yawona nange nensooka ngendera ku byekyo naye nga bankansolinga omulundi ogwasooka ne baŋŋamba sukaali tawona mu ddwaliro batyo ne baŋŋamba naye omuntu asobola okubeerawo okuba nga bakamuzaala paka naakula n'akaddiwa oba naafa kintu kirala nga te sukaali si yamuse gwe kasita ogendera ku mateeka g'abasawo n'eddagala n'olipimanga we bagambye n'okumuwa naye ate tebagambye agenda kubeerawo era teri agenda nakumanya nti omwana mulwadde wa sukaali era bwekityo bwe kiri naye obuzibu bwe yafunamu ng'ate ye omwana bambi bw'abeera ku ssomero ne bamufulumya bamulabako kolumu ng'agenze mu kiraasi ng'agenze mu staff room okwekuba empiso n'afiringa small bwe yakomawo ewaka n'aŋŋamba siddayo ku ssomero ne mugaa togenda kuddayo ku ssomero kati ogenda beerawo otya era olina ogenda ku ssomero n'aŋŋamba siddayo ne mugamba ogenda genda abaana bansikirira bwe bandaba bwe bati buli omu asemberayo agamba ngenda musiga obulwadde ne mugamba obulwadde tebukwata bagambe tebukwata nengenda ku ssomero ne mbagamba bwe nabagamba ne baŋŋamba tugenda kyandolinga ne baŋŋamba bagenda kola ki bajjanga muyita nga tebategedde kiki kye bamuyitira era ne bakuba parade ne bagamba abaana ne bagamba ketuddamu okulaba omwana yenna ayogera n'eddayo ekintu ekibi tugenda kugoba ku ssomero bambi abaana ne bawuliriza naye era balwawo nga bw'omanyi abaana bateera nga temugulamu ng'ajja akulopera ne mugamba ku ddwaliro bakugamba batya bakugamba buli bulamu bwo gwe ayogera muleke tobavuma tolwana baleke bwe bulamu bwo oyagala okufa nti nedda oyagala okubeerawo nti ye kati gwegendera ku kye twakugamba naawuliriza mukazi wattu naye obuzibu obuliwo omwana wa sukaali oba obeerako nga gwe omuntu omukulu n'otabeera na mwana muto bamugamba tolya sweet stone cake naye buli lwalaba banne nga balya naye abaawulira bubi era ogenda okuddamu okumupima n'omubuuza walidde ki n'omukambuwalira nagaa nanywedde sooda n'omugaani yamukuwadde mami sigenda kuddamu
n'ogamba ati kiki kyetugenda okuzzaako okiraba n'asirika bwe buzibu obuliwo nti omwana omuto takuumika ebyokulya n'omugamba ne bakugamba tuwe greens fruits n'akugamba koye ebidoodo byo sigenda kubirya sigenda kunywa bikyayi bye bitaliimu sukaali n'omugamba bw'otaaliwe ogenda beerawo nti oyo gwe mulaba azaagala ozisiise ate nga teziri supposed kuba nsiike alina kulya bboyi bwe bubuzibu obuliwo naye nga tewaliwo kintu kirala kyonna kuba tumujjanjabe bulungi enzoli ne bwangamba muweesere agenda kumuwonya okuva ku kyenatuukako sisobola bingi balimpa abangi babingamba gendako wano sisobola kugendayo okujjako nga tugenze mulago ne batuwa eddagala nga liweddeko kyekyo kyekiri
Thank you so much. Tweyanza nyabo olugendo era kati ndowooza era tukweyanza okulabirira omwana si kyangu gabwoyogera. It's not an easy thing. I take care of the child with diabetes or with a chronic ailment. In the discussions, there are certain things that I've looked at. One of them is stigma, of course, and discrimination. That's what we should be looking at. And also heard from just for now, how she was cheated and fleeced and maybe she became desperate and people cheating them with their money. And such a kind of scenes and instances are even common in most of public health facilities. Just like I said, it came from lab or something like that. And then, of course, we'd also be looking at, I've faced so many questions about herbal medication in managing chronic ailments. And I know, and also how you people come from the media. Most of your media houses have given this people platform to speak about how their herbs can cure everything. So, and you have also told me those so many questions. I think as we discuss, as people from the technical side will be making their presentation, we will already all those and make sure these questions are answered before we leave here. Mr. Johnson, something to say?
I thank you all for being so attentive. As I said earlier, I've been living with diabetes for the last 19 years. I said I've been living comfortably with diabetes for the last 19 years. The reason has been, as other speakers had said, you have to eat well, that's nutrition. You have to do some exercises. You need that education also to come in from time to time from the health workers. You have to be on regular drugs all the time, self-monitoring, and observe the sick days. I live in a rural setting, down in a mine walk. But the challenges of diabetic patients they are faced with from time to time, the shortages of drugs at our health centers. Our patients, my colleagues, the diabetic patients or people living with diabetes are forced to be dragged away by the herbalists as a way of looking for a survival. And that is a very big challenge, because we face in the rural settings many deaths due to misinterpretations of the herbalists. If someone came to tell me that he can cure, if I had a heart and is a heart, why can't I run away and say I go for that one? But because I've lived very close to the health workers, I know what to do. I also wonder whether one day the Ministry of Health will come up and put restrictions on the herbalists. Our colleagues are losing. We are losing many people because of the herbalists. If that one can be screwed to the ministry, I think it will have done a better serving to the nation. For I know the magnitude of the diabetic epidemic dictates more aggressive approaches to treatment. Therefore, maybe the present system is weak, that it can allow by slip of the tongue. I heard someone commenting that the media gives them platform to deceive. Whether that is true, but it could be true. Look at that. So, for me, the clear evidence I've gone through suggests that early intensive treatment results in significant decrease of complications. And that if we went clearly to that, there would be no complications or minimal complications. I beg to submit.
Thank you so much, Mr. Nancy. These are stories that people don't hear, especially when it comes to NCDs in children. People really believe that NCDs only affect older people. But that leaves children uncatered for. It leaves them vulnerable. When we were in school dealing with these issues, a lot of people thought we were just lying, or we didn't know what was going on, or we just wanted favoritism, or we just wanted, not to go for prep, or we just wanted to go home. They didn't take us seriously because we had real issues, but no one would take them seriously. So I think it's important that people like Hidayah are speaking up now and showing people that this life is not easy when you don't have the kind of support that you need. And when that support is not there, the chances that you're going to make it in school, they become very low, you know? For a lot of us, you're struggling, you can't get the kind of food you require, you're struggling to get your medication, they don't want you to go home to get a review by a doctor. Ultimately, your health is suffering. If your health is suffering, you can't do anything else. You understand? So if the health is bad, you can't achieve. They want you to get, you know, grade 1, first grade in P7. How are you going to do that? Even if it's whatever class you are in, even if in university, there are students in university also struggle. And people think that as you grow older, even with diabetes, somehow you can manage on your own. But it's almost impossible without that support. Even at university, people still need support. So that support should go from childhood into the transition from childhood to adulthood, even early adulthood, you know. Young adults are also in need of that kind of support. They need to understand what they're dealing with. They need to have access to medication. They need to be able to go and report when something is not right. But where do you report? I know right now a lot of patients come to me and say, Edith, where do we go when we have issues? So I would ask that our policymakers consider having a helpline for people where they can go to report when things are not going well. During COVID, a lot of patients needed help, but they had nowhere to turn. And a lot of them would end up struggling in their own, and a lot of them gave up. I know a mother who told me, I've given up. I have nowhere to find food for this child. What do I do? You know, so what chances does that child have of a bright future if they can barely get food? So the need for the support is really there. And you know, the youth are really willing to support each other. We really are. But we lack the resources to do it. And we are trying so hard. But guess what? We are also other youth living with NCDs. So we have the same problems as the people we are trying to help. You understand? So it's very complicated to be able to help someone when you need help yourself. You know? I've been in this work of advocacy for the last 3 years. And I've been sick that whole time. And I just refused to go to hospital because I knew, first of all, it will almost be impossible to find out what was wrong. Secondly, I also knew I probably can't afford to pay for the services that I need. Until COVID came and I was down, completely down. And I was very fortunate that at that time, I had family that was willing to step in and find out what was going on. So I was diagnosed with another NCD. You understand? So these diseases tend to come with others. Already having one is hard enough. Now you have a second, then a third, then they are not well managed, then you start adding on complications. And none of it is any of our fault. We didn't ask for this, it just happened. But now we have to pay for it because guess what? If you don't have the kind of support that you need, there is nowhere that you're going. But our youth with NCDs have a bright future. We just have to support them to get to that future that they deserve. I really, really thank you for this opportunity to speak up. And I thank you for the good work that you're doing. I really appreciate Sister Ejan because when I used to go and educate at Chirudu, she'd look at me and she was so happy that I was educating. And then before I left, she'd always make sure she had a snack for me and something to eat with tea. And it would really bless my heart because at least I had some lunch. You know, I didn't go home hungry, struggling with hypos and low blood sugar episodes. And that really, really touched my heart. So when she says she advocates and she educates and she really does. She is not telling a lie. So thank you so much for all the good work that you do. But we are praying and hoping that you'll involve youth in all these programs because the youth want to help. Because they want to help themselves. So they're not helping anyone else but themselves. So they want to work. But they can only work if they're supported to do the work. Thank you very much.
Thank you so much, our panelists. We are having the next session.
My name is Lynn Komsha. I work with Urban TV.
I am very passionate about non-communicable diseases for one reason. I come from a family that has gone through a lot of these diseases. Growing up, I found my grandmother, who is almost 90, suffering from high blood pressure, suffering from blood sugar, which is diabetes. And I don't know for how long, because she used to tell me stories of how she lost about 5 babies and no doctor knew what was killing the babies until they discovered she had diabetes, and that was the reason why she was losing the babies. After finding out, then they put her on medication, and eventually she started giving birth to healthy children. Years later, my father, who is now diabetic, told us while we were growing up, I don't take sugar, I don't drink anything sugary. He never took any sugar at all. He would only eat, I think it's called ndizi in Uganda, if I get it right. Kabaragara in our language. Now, when I was at campus, university, my mother calls me, your father has been admitted. He can't talk, he can't do what? And like, what's the problem with him? He never falls sick. Then I'm told he has diabetes. I'm like, but he couldn't take sugar at all. He's not been taking sugar. He cannot actually have diabetes. What is the cause of this? How is that even possible? So this has been part of my life, and I don't have diabetes, thank heavens, but trust me, the fear I live with every single day. I wake up with a headache, I'm running to the hospital. Do I have diabetes? So it is, I know it is a very huge problem. This brings me to how the media and the community can help. We have had herbalists, we have had people talk about the role herbalists play. They're all over the media, saying we can, we can cure blood sugar, we can cure A, B, C, D, and Z. They can't. They cannot. We don't know how true these things are. Yes, the media is running after money. But you as a media person, you need to play your role and know that here is a disease that can be managed, but we must go through the right channels and we must go through the right procedures. There are media personalities who are diabetic that I know, and they'll tell you their stories. And it is very alarming when you look at the statistics. This year's theme is looking at the role health practitioners, most importantly nurses, play. We downplay their role because you walk in and you say, nurses are all very grumpy, they're tired, they're annoying, they don't have time for you. No, they do. They play such a huge role. It's only you know and appreciate that role. Where does the media? We are all here. We run to cover these events, but are you learning a thing or two as the media? Are you picking anything from these dialogues we have? Yes, you have to make money. You have to, take stories to your media company. You need to write stories. You need to produce stories. But what stories are you sharing? Are you reaching out to somebody, or you're just rushing after money? Tomorrow it could be with diabetes. And you'll sit there, okay. I remember a certain doctor did ABCD inside, and they talked about how to manage diabetes. Now, before I can ask the media that is here to ask the very questions you would want to know, I haven't had, because we have had people going through who are living with diabetes. They have told us one has diabetes type 1, and others have diabetes type 2. We have had presentations here, and I think most of us need to know what is diabetes type 1. Who does it affect? At what point does it affect you? We have seen a child who's almost 10, and she has diabetes. Is it type 2? Is it type 1? Okay? And how do we manage this? My family has type 2 because it gets them in I don't even know how it happens, but over time I have learned We have had to adjust our diets. Do I have to adjust my diet right after I am diagnosed with diabetes? No. Can I start now? Does that help? I keep asking myself, my father never took anything sugary. He totally ran away from anything sugary. But then he got diabetes. So I'm asking myself, and many people ask you, is sugar really the cause of diabetes? Doctors in the room, we are journalists. Yes, we have covered these things day in, day out. But trust me, we still don't know what causes diabetes. We just go and tell stories, like we are supposed to. We still don't understand the simplest cause. No one here, I'm sorry doctors, but you all came here, you haven't told us what is diabetes. How do I define it? For example, if I'm going to perhaps have a show, the other day I hosted Sister Ejan on Urban TV, and we're talking about diabetes. We actually had a gentleman who's had diabetes from the type 1 from the time he was 14. It was very challenging. He was a gentleman. He's telling us he has to have insulin, an insulin injection every single morning, every day. I wanted to know, how do I live that life? I had an auntie who died because she was also on insulin. And I used to see her inject herself every day until she lost the battle to diabetes. She just collapsed and that's it. So we need the nitty-gritties. We need to know the tiny, tiny things that, spur, that aggravate diabetes. I am healthy. But what can bring the diabetes? What can spur it? I might be sitting for long hours, okay? It might not be the cause of diabetes alone. It might be an amalgamation of a lot of things. I want doctors to help us understand. I want them to diagnose what diabetes actually is and paint a picture. Because many people are like, diabetes, I don't have energy, I drink too much, I pee too much. Then what? So doctors, while you're explaining these things, help us understand. So that when we are reporting these stories, we are reporting from an informed point of view. I need a doctor to explain what is diabetes type 1. They're basic, okay? They're basic. You might expect everybody here to just Google it. But from a doctor's perspective, it is a different story. You have had stories of what people have gone through. It's challenging. And now we have COVID. Let me tell you, we didn't pay attention to non-communicable diseases before COVID happened. I am sure most of you agree. Most of us didn't really care. That one has blood pressure. You'll manage. That one has diabetes. It's okay. We really did pay attention until COVID-19 happened, and they told us if you have pre-existing non-communicable diseases, you're at a greater risk. Do you know that? No, you don't. I've been telling my friends. I have friends who drink too much and they have high blood pressure. I'm like, why are you killing yourself while you're looking? And they laugh at me like, life is short. Yes, it is short. What have you done in it? Would you rather waste your life somewhere like that? So bringing me back to what we are looking at and the role the nurses play in our lives is that make a nurse your friend. Sister Ejam was here. We've had stories about her. Very wonderful stories. But how many of you are able and are willing and are ready to tell the nurses' stories? Journalists in here, you write stories, you want to quote the authorities. Have you looked at what role the nurses are playing? When they do whatever they do, when you go to hospital, I'm sure, because most of you go to hospitals, when you get there, what does the nurse do? Have you ever thought of saying, okay, I'm going to Chirudu, I'm going to Mulago Hospital, and there's a specific nurse, I'm probably suffering from ABCD. There's a nurse who's paying me attention. Can I write that story? Can you write that story? Can you produce that story?
and project and show what a nurse really goes through. Because they're human. Most of you castigate them. But you need to focus on what they're able to do for you. This is why World Diabetes Day celebrates the nurse, recognizes the nurse, recognizes health practitioners, because they play such a huge role. Now, the media, before we can engage so far the people who have talked to us, most of you are in denial. The media practitioners, I'm speaking to you right now. You don't care about your health. You don't really care about your health. You only hear about these diseases when you're covering these events. And once you hear about them, you just run, report, and that's it. You don't remember. You have to go and get checked. You don't remember. You have to spare some time and do some exercise. You don't remember that you have to spare some time and make yourself a healthy meal. The media practitioners, we go through a lot at work. You're literally busy going through, checking research, you're interviewing A, B, C, D, and Z. You're not caring about, when lunchtime comes, okay, I don't have time for lunch, what is nearby? You grab this, you eat it, and that's it. At the end of the day, you have ulcers. At the end of the day, you have diabetes. Low, your sugar levels are low. You don't know what's causing it. So take time as media practitioners, as you run about your daily activities, because you have to keep us informed. Take care of yourselves. Take care of yourselves. Prepare yourself a healthy meal. Have a restful night. Go get checked. Once in a while, go get checked. Do a thorough check. And this does not only go to the media. It goes to everybody of us here. Even doctors, I'm sure you also carry out your own checks every once in a while. So it is very key and very important that you do a thorough check. Every once in a while, you need to know how healthy you are. COVID-19 has exposed all of us, including the health facilities, including the health practitioners, including us, all of us. It has shown that there's a lot of gaps, and there's a lot of gaps in our own lives. So you need to take extra and extra care. I can go on and make noise about these things, but now I want to open this to the media, to whoever has a question. My questions have been, what is diabetes? What causes this? I'm sure most of you doctors think this is really basic. Yes, you think it is basic knowledge, I should just Google it and go, but no. We need to know. We need to know how to go about it, okay? And what really, really can you and I do as a community to help each other? At what point, because you have heard from the lady whose friend helped her get a leg, she was helped. She needed help with her leg, and a friend stepped in. So a community, it's you and I. We need to help each other. So how do we do it? And how best can we look out for each other? These are some of the things we need to focus on. So I'm going to open this discussion to you and ask all your questions, and we'll have the doctors in the house, help us answer these questions.
Thank you, Ms. Lee. I think that's the presentation Mr. Lee is going to hold here in the afternoon. He will be able to answer all your questions. Thank you for those questions. Actually, we really need them to be answered. On Ministry of Health and other partners in managing NCDs, we need to know what our leaders have for us, policy makers and government people. Please welcome Dr. Mugabe Frank for this session. Thank you so much. Dr. Mugabe.
Good afternoon, ladies and gentlemen. Thank you for turning up in the big numbers. the presentation I'm making is a future presentation. I call it a future presentation because as the Department of Non-Communicable Diseases, we are a new department which needs to forge alliances with many groups, including the media fraternity. We are a different department because for us we take care of many conditions, and the media needs to know that we are not so advantaged. I don't know why it's not coming on. We are not so advantaged like other departments, other programs, which makes it easier for you to report. If we are reporting on HIV/AIDS, you only talk about HIV/AIDS. TB, you only talk about TB. Malaria, only malaria. But for us, non-communicable diseases, I even don't know how many there are. I even don't know how many there are. You need to know that. The ones we are telling you about, diabetes, hypertension, cancer, asthma, chronic pulmonary diseases, mental health, those are the major ones. Am I clear?
100%.
Those are the major ones, but they also have other related complications. Because when someone suffers from kidney disease, that's an NCD. And you can get kidney disease after your diabetes. You can get kidney disease after hypertension. You people don't know that. These are things you need to know. You can, when we talk about cancer, they are of different forms and they can go to any organ of the body. The only one I've not had is cancer of the hair. I have not had cancer of the what? Of the hair, but your beautiful skins can be invaded by the notorious cancer. Diabetes can invade any organ of yours. The only organ I've not had, Dr. Rumu will correct me, is the hair still. But you can get wounds, anything on your body due to diabetes. Are we clear? You can get anything, you can get any organ failing because of diabetes. And it's associated with many other conditions. To me, it does not surprise me why many diabetics with COVID are actually succumbing. Because we already know that the diabetes has a strong relationship with tuberculosis. That is clearly documented by World Health Organization. We already know that many HIV positive patients who are living faithfully on ART, as they age, they graduate into diabetes, hypertension, and these other conditions as you age. So while we want to grow beyond the biblical age of 70 years, we should be ready that these conditions are out there waiting for us. To be able to address any CDs, we must be able to work with everyone. For us as the Ministry of Health, we know that we don't look at any CDs to be having a medical solution. Am I clear? Because the genesis of NCDs can be traced anywhere. From our homes, from our kitchens, what we cook, from our lifestyle, how we enjoy and how we spend our money, also from our poverty, from our stressors, yes, from our stressors, from our riches, and from development. Because when you develop and become rich, by Ugandan standards, you find you don't want to walk. You want to drive, or at the worst, you move by motorcycle. To an extent, if someone meets you walking, you feel embarrassed. Then in the future, you want to walk on medical advice. Are we clear? Yes. When you have money, you don't want to buy vegetables in a restaurant. Then if in the future you eat them like a cow, whether they have told you or not, you find you are hunting for them, you are growing them in your backyard, you are doing all of those things. You are admired when you have put on weight, then you start shedding it on medical advice. Are we clear? Are we clear? Yes. You want to consume as much alcohol, more than the stock in the bar. Then at the end of the day, you are consuming nothing. Then there is this problem of smoking cigarettes and other substances, which has also become fashionable. It's also related to development, because when we are developing our places, and our countrysides, our cities, you find that there are no playgrounds, there are no walkways. The places are congested. Even if you want to walk, you cannot walk. We have to work together to address any cities. I like the presentation from the person who has just spoken before me. It's challenging to understand NCDs, because NCDs, like I've said, are many. At times we find our focus, when we are talking about diabetes, you find we are forgotten type 1 diabetes. We tend to focus on the lifestyle diabetes, but we forget that there is also this diabetes that also comes as a result of some genetic challenges or some autoimmune issues, the one we see in children. And remember, wherever there are children, children are most at risk. We regard children as voices when it comes to any condition that they may have, because they never explain themselves very well. You will also find that as NCDs, we are a very important department, but also apparently the most least resourced. And there are many reasons that I may adduce. One, it's you and your NCD. When you have it, you are not going to pass it on. Did you know that? But you can indirectly pass it on if you expose people to poorly cooked food, fatty foods, what you are like passing it on, but not directly. So, globally, NCDs may not be seen as a security threat, but definitely NCDs are economic threats. Are we clear? People die young. People live, but with disabilities. You had heart expiring. You live with no limb. You have seen people who live post-strokes. He or she is alive, but not able to do anything. Are we clear? Then you live, those who are lucky to live also, you live with your pocket. Because of their chronic nature. If you are lucky and there are no serious complications, you live with your pocket. You must have a monthly medical bill. And not a small bill. I can assure you, not a what? A small bill. Today we are lucky that they have screened us for diabetes and they have taken our BPs. But in our happy lives, most of us don't offer ourselves for such screening. In the private clinics, usually a BP check is 2,000 shillings or 1,000, less than $1. But you don't have time to branch there, even on your way home, at least once every 3 months. When you branch there with that insidious headache, that scratchy headache that you are not understanding very well, and the doctor tells you, you have packed your car out and the doctor tells you, we are going to admit you. That's when you realize what I'm telling you. You drive in, you park, they check, then the doctor tells you, we are going to admit you. If it was the police, you would start asking yourself, what crime have I committed? If they just walk to you until you are under arrest, what crime have I committed? But then we are going to admit you. And you just say, no, I can't be admitted. They say, please, we are going to admit you. Because your blood pressure is rating 200, over 120. And the doctor thinks you cannot go home. Anyway, let me go to the presentation. So I describe this presentation as a future presentation. I have an opportunity to, I'm Mugabe Frank, I have an opportunity to take you through the mandate of the mission of the Ministry of Health. We worked significantly to reduce the preventable burden of diseases, disabilities, and deaths due to non-communicable diseases. And we are clear that we want to do this through a multi-sector approach. So we know as Ministry of Health that everybody must be on board. And the department is geared to coordinate the efforts that are aimed at preventing and controlling these diseases in the country. We have 6 strategic objectives. The first one is to coordinate and strengthen advocacy. What we are doing here today is advocacy. We give knowledge, but also advocacy. So what we will do after here, we will be real advocacy when we send out messages that are clear and well targeted. And we are available to see the strengthening of the multi-sector capacity and provide any possible guidance. Also to coordinate efforts that are aimed at reducing modifiable risk factors. We cannot do it alone, but we would be happy to see smoking, excessive alcohol consumption, physical inactivity, and consuming unhealthy diets really going down. And we will be happy to see the health system strengthened. The health systems are MoH, it's government and all the players strengthened to address NCDs through people-centered primary health care. And we're also interested in research because we need much more information. Then we're interested in data through monitoring and evaluation. Because without the data, we cannot know much. So in summary, we see our responsibilities as provision of technical guidance, formulation of policies and guidelines. We have a responsibility to plan for this country. We have a responsibility to mobilize resources, including human. So when we have the media here with us, for us, we have mobilized resources is not only money. We have a responsibility to advocate, coordinate, and network. When we become well established, we shall set standards, and also together with you institute quality assurance measures. At the moment, we are interested in seeing services increase. Then once they have increased, we shall go to this. Capacity building is very key, and we also look at this as a capacity building session. Training, coaching, mentoring, and as I've said, monitoring and evaluation. So as non-communicable diseases, we have a number of challenges, but we feel we have a challenge in the leadership and the policies. We need much more leadership and ownership of non-communicable diseases. We have a challenge of funding for NCDs. We are not well coordinated, and this is one of the reasons why I'm making this presentation. We need it to be better coordinated. There is a problem from the testimonies of human resource capacities at various levels, even services, infrastructure, equipment gaps. There are nice things we would want to put in place. We have not yet done it. Medicines and other laboratory services supplies is also an area that challenges us. We feel we don't have enough data. There is limited documented evidence, and there is less reporting. For example, we haven't gathered the reports that we are supposed to get from the private sector. There are many private clinics that handle diabetics, and we don't have those reports as Minister of Health. Then we have a challenge of the focus on infectious diseases, including COVID. Those are our rivals. Infectious diseases, HIV, malaria, TB, now COVID. Everybody thinks infectious. Every development partner thinks infectious, while we continue to melt under diabetes and cardiovascular diseases and cancers. Of course, we have many non-communicable diseases. It's also a challenge. When you want to focus on diabetes alone, you are reminded that there are also cardiovascular diseases, there are cancers, there are respiratory diseases, and they have a host of complications, like I said. And we will have a problem of a huge awareness gap and global influences. These ones have not even spared the so-called educated. Even educated, they don't know what to eat. So there is a very huge gap, and people are exploiting this gap, especially the traditional healers and others. Next. So, why NCDs, and why do we need immediate action? There is no doubt, as the commissioner said, that the NCD burden has been increasing. We last did a survey in 2015, and we are preparing to do one next year. If COVID had not disrupted us, we would be in advanced stages. But there is no doubt. Last time we thought that we had 1.4% of diabetes generally, and about 3% in the urban centers. I wouldn't be surprised if we find that this proportion has doubled in the next survey. Then we have seen LCDs have defined themselves as death sentences. All of you seated here, quietly you may find that you have lost a relative to an NCD in the last 1 year. You haven't lost many people to COVID. Let's put COVID aside. But you'll find you have lost a relative due to a cancer or a cardiovascular disease, such as strokes and others, road traffic accident, even asthma is actually killing. I was shocked earlier this year when a brother of a friend of mine succumbed with asthma. A young man of about 35. To me it was shocking. NCDs require a multi-sector effort from the family, government ministries. I couldn't mention all, but the Minister of Finance will need to put money to the population. The money allocated to NCDs is the money to the population. Justice, gender, and education. NCDs have socio-economic effects which are far-reaching. You will not suffer from an NCD and the talk of saving money. Instead, you will save. You will save what you save. And if you didn't save, I don't know. Then NCDs are characteristic in causing premature death and disability. So we need a partnership. Partnership. We need to partner with everybody. I've put a full list from development partners to associations and patient groups. But in between there, we have the media, we have professional associations, we have researchers, we have the academia, we have civil society organizations, so everyone needs to come forth. We have government departments and agencies. We have the private sector. Next, we have the private partnership and others. So we look at availability of partners as an opportunity. And through partners, we can get additional hands, brains, we can have a coordinated mandate and coordinated support and coordinated resource mobilization. Partners can help and lead in advocating for NCD inclusion in the national agenda. We as Ministry of Health, there are certain things we cannot say, but which partners can say. And if works for government, if I say certain things, my bosses might call me for question. But if you say them and they are true, then they might ask me to see how to plan for them. So if you are not mobilized and you are quiet, NCD loses from the national. Where the national cake is nice to grow. Strengthen advocacy for increased interest of senior political leaders and different arms of government. This is what you can really pass in. Strengthen multi-sector capacity among the relevant stakeholders. If we work together, this can be strong. Shall promote local and international cooperation. We need a strong partnership locally and partnership with our international partners. Forge new collaborative partnerships and enhance capacity for implementation, strengthen monitoring and evaluation of any implementation, including any plans that we have. So there are not many advantages of a coordinated partnership. Coordinated partnership will let us focus national priorities for MCDs. It will help us to expand implementation. There are cost savings because when the partners are not coordinated, for example, they can implement in the same district, in the same village, do the same thing, yet they will go to another area. Information sharing for planning, cross-learning, we keep on learning from each other and better through partnership. And we can reach a wide scope of beneficiaries. And it also minimize any possible conflicts. So when you are doing something together, you keep going. This was on 2019 National Physical Activity Day. We exercise